conversation. We'll get started, I guess. It's 1:30. Thank you for coming. People on Zoom, you are muted, so please stay muted. Um, if you have any questions, put it in the chat and we'll ask the speaker at the end. If you're in the room and you have a cell phone, if you can please silence your cell phones, that would be greatly appreciated. Pushpa is here and she is going to introduce our speaker for today.
Hi, good afternoon. I'm Pushpa Kalra, and I'm the facilitator of this particular lecture. Ken Rand and I are cooperating and putting together this Medical Matters series. Today's lecture, as you see up here, is by Dr. Leslie Hendeles, a professor emeritus from the College of Pharmacy at UF. He's also courtesy professor of pediatrics in the pulmonary division of the College of Medicine. He earned his Pharm D degree at the University of Southern California. His research has focused on methods of determining bioequivalence of generic inhalers, delivery of inhaled drugs to young children, and improvement of adherence to asthma medications. He previously has served on FDA's Pulmonary Allergy Drugs Advisory Committee and the Coordinating Committee of NIH's Asthma Education Program, as well as CDC's expert panel on asthma guidelines for emergency medical services. He was the co-chair for the Florida Asthma Coalition from 2012 to 14. For several decades, he provided advice on the use of drugs for patients with difficult to manage asthma and taught pharmacy students, pediatric residents, and pulmonary fellows about the use of medications in the pediatric pulmonary clinic at UF. Currently, he volunteers in a pediatric severe asthma clinic once a month and consults with industry to help make generic inhalers available. Please welcome Leslie Hendeles.
Everybody hear me? Good. Thank you very much, Pushpa. So, testing one, it's too loud. Testing 1, 2, 3. How's that? That's good? Good. Somebody said yes. So why did Sudafed, we need to turn it down because you want to leave it up. Okay. I should turn my hearing aid down then. So why did Sudafed stop relieving stuffy noses? So there are two Sudafeds. This is the original Sudafed, which contains a drug called pseudoephedrine, a nasal decongestant that's very effective at relieving nasal stuffiness and opening up your sinuses. And even for scuba divers, it helps clear their eustachian tube. There was a law passed, and I'll get into that, that required it to be put behind the counter. It does not require a prescription, but you have to show a driver's license, you have to be 18, and you can only get 120 tablets a month. And they put your name in a database and make sure you're not going from CVS to Walgreens to Publix to stack up on it, because back in the day, and particularly here in Florida and even Alachua County, there were people making illegal methamphetamine by mixing the pseudoephedrine with Drano. And they did it in their kitchens, and they were beginning to sell it. And so in an effort to reduce the epidemic of methamphetamine, speed, the Congress, in its well-meaning attempt, was to prevent anybody from getting a large quantity at once so that they couldn't make methamphetamine. It was for naught, because what happened is the Chinese have been making the methamphetamine pure and going through Mexico and importing it into the United States. So there's They may have removed it temporarily, but now people who have a stuffy nose or clogged ears from flying, for example, can't get the real Sudafed in an airport or in a fast food store, etc. Sudafed PE is what the company, what they did is they replaced the pseudoephedrine with phenylephrine, which is what I'm going to be talking about. And phenylephrine is being, so you can see here, the only difference between the two packages is the PE. So phenylephrine is not only in this product, but in 261 other products for cough, cold, and allergy. And I will show you the data. It doesn't work. It gets inactivated in the gut. This is my colleague, Dr. Randy Hatton, who is still on the faculty of the College of Pharmacy and participated in all of these efforts to get the FDA to take the PE off the market because it wasn't effective. So this is a shot of a CVS, and there is just dozens and dozens and dozens of products. I don't know how anybody who's not a pharmacist can figure out which product to use because it's so confusing. And I've spent a good amount of time trying to learn that and teach pharmacy students and others how to which products to use when. At any rate, there are 261 over-the-counter, OTC stands for over-the-counter, which is non-prescription products that contain phenylephrine. So my take-home messages are, oral phenylephrine is ineffective as a nasal decongestant, but it's safe. It doesn't get into the blood, so it doesn't hurt anything. 99% of the dose that when you swallow it gets inactivated in the gut. That's why it doesn't get into the blood. And in 1976, the Food and Drug Administration panel that reviewed these products reached the wrong conclusion. They said it was safe and effective when in fact it is not effective. And then last but not least, and perhaps most important to the consumer, is there are several truly effective over-the-counter products available for stuffy noses. And for example, if you have allergies, nasal steroids like Flonase or Nasonex work terrifically and are very safe. So removing phenylephrine from the marketplace is not going to deprive anybody from having an appropriate drug. Disclosures: I have not received any funds from a company that makes these products since 1993. At that time, I was involved in a symposium on decongestants that was sponsored by Procter & Gamble. Here's a little bit quick review of what the FDA's history. In 1906, Congress passed the Pure Food and Drug Act, and what that said is that drug products could not be mislabeled or tainted. So the idea was to prevent it from having ingredients that might be harmful, that are not related to the effectiveness of the medication. And if whatever the label states in terms of the content and the milligrams, it had to be accurate. In 1938, the Food, Drug, and Cosmetic Act was passed, and that mainly focused on safety, but it did give Congress the funds to fund the FDA. It's an interesting story on its own of how that happened, but there was a product, a sulfa elixir for children that was manufactured by a company, and they used antifreeze to dissolve the sulfa drug in it, and there were 100 children that were poisoned, many deaths as a result. And so that stimulated the Congress to pass this law that now requires every product, both over-the-counter or prescription, to be tested for in safety studies. In 1962, the Kefauver-Harris Amendment added the ability of the FDA to require evidence of effectiveness. And that created a real problem. There were thousands of products on the market already that had been approved for safety reasons, but had never been were not required to demonstrate effectiveness. And the FDA then put together a process called the monograph process. This is where a panel of experts outside the FDA joined with the FDA staff in reviewing the ingredients, and then they would decide if the ingredients in these products, a particular ingredient, whether it was safe and effective. They were supposed to be safe and effective in order to be approved. I've been asked, well, what's the pathway of approval of drugs in the FDA? And it's divided into two groups. Prescription drugs have 3 to 4 phases. Phase 1 is where they test the safety of a new drug in otherwise healthy, non-ill patients. They look at what dose is safe and tolerated. In the phase 2, they study the effectiveness in a small sample of patients with the disease. So in the case of nasal stuffiness, if you had a product that you wanted to promote for treating allergic nose, they would take a small group of people who would have a runny, sneezy nose during the pollen season and test them at different doses so they could tell what dose actually controlled the symptoms. And then the last was 2 large multi-center studies, hundreds or thousands of patients, and they tested both the efficacy and safety of the medication. In addition, FDA would require, depending upon the drug and the formulation, they might require absorption studies or drug interaction studies, and on occasion, they will require determining the genetics of the drug. Non-prescription drugs are mainly approved based upon this 1976 monograph process. And in that setting, and I'll show you some information as it relates to decongestants. The other alternative is they could take a prescription drug and make it over the counter. And a common one that you might know about is the antihistamines like Claritin and Zyrtec and Benadryl were all prescription drug products, had been on the market for 10 years, and Blue Cross sued the FDA for requiring them to require a prescription, and they won the lawsuit and then motivated the FDA to convert those products to over-the-counter or non-prescription. And so that's one other process. And then having a new drug application product is tested in a population of patients and can get approval. The oral contraceptive pill that recently got approved, Opill is the brand name, was made over the counter by a new drug application, testing it on efficacy and safety. The 1976 FDA over-the-counter panel recommendations for oral decongestants were whether they are GRAS, which stood for generally regarded as safe and effective. And they judged in 1976 that phenylpropanolamine, and that was in the contact cold capsules, and Dexatrim appetite suppressant. You folks are old enough to remember these. When I talk about this to young pharmacy students and medical students, they don't know what I'm talking about because they're not available now. So phenylpropanolamine was the first, pseudoephedrine, which was the pure drug in Sudafed, and then phenylephrine, which was in neosynephrine tablets. And if you go from 1976 until the turn of the century, all of the products had either phenylpropanolamine or pseudoephedrine. So some of the drug companies must have known that the phenylephrine was not effective because they weren't using it, even though it was approved by the FDA. Phenylpropanolamine was removed around 2000 because it was determined that it, in patients who used the Dexatrim product for appetite suppression, It was associated with hemorrhagic stroke, bleeding in the brain, predominantly in women who were using it for appetite suppression. And one of the thoughts we had, since it never was related to taking the cold medicine, only for dexatrim, it really didn't effectively suppress the appetite. And so these patients must have increased the dose and then got the adverse effect. Pseudoephedrine, of course, is still available in the product that's behind the counter, and phenylephrine is the one that is in the multiple products. So back in 1993, for that symposium I mentioned, I had to write all of the people participating had to write papers, and it was published in a supplement to the journal. And my assignment was selecting a decongestant. And back then I said phenylpropanolamine and pseudoephedrine, but not phenylephrine, are effective decongestants. And there were a couple studies that I ran across that suggested that it didn't have good absorption, and another study suggested that it wasn't as good as pseudoephedrine. So that was back in 1993. I never thought about it after that because there was maybe one product out of all of these products in the market that had phenylephrine in it, and so I never thought about it until around 2005. That's when the Combat Methamphetamine Epidemic Act of 2005 was passed, and this moved decongestants behind the counter nationwide: ephedrine, phenylpropanolamine, and pseudoephedrine. And it left only phenylephrine in front of the counter in 261 unique products, with about 1.8 billion with a B in annual sales in 2022. So we're talking about really big money here, and we were maybe making some good trouble. So my colleague, Dr. Hatton, contacted the FDA through what's called the Freedom of Information Act and requested the data on all the products that was used in the 1976 evaluation by the expert panel. And he and Dr. Schuster, raise your hand if the name Dr. Schuster rings a bell. He's a retired professor of biostatistics from the university. At any rate, they took the raw data and analyzed it to determine whether it was effective in the studies that were used that were claimed to be effective. And this is the analysis looking at the difference in nasal airway resistance. So they measure the airway resistance. I think I was missing a slide. They use a way of measuring the flow of air into the nose by the amount of resistance, and it's a scuba mask with a conducer connected to it, and they can measure if there's a resistance to flow. If your nose is stuffy, it's swollen on the inside, and so there's a resistance to flow. And this is nasal airway resistance in the various studies that were submitted to the FDA. And I want to just point out that if you look at this, for example, is saying that there was an average of 40.96% of the nasal airway resistance was reduced in this particular study. And the reason why I point out the Elizabeth Biochemical is that they had of the studies that showed efficacy, they had most of the studies, and it made Dr. Schuster wonder why was this one company's study different from the other companies when the very some other companies, like in the Huntington study, it was the same protocol, the same sponsor, the same dose, but it wasn't effective. And he did what was called a forensic statistical analysis. And you can see for this one, where it's 40.96, the first digit after the decimal point could be anywhere from 0 to 9. And in his analysis, looking at the individual data in that study, there was something like 2/3 of the patients had a 5 after the decimal point, but that just couldn't happen from randomly. It had to mean that somebody was filling in the data. And he said, quote, "These data indicate a crystal clear pattern of disproportionate appearance of the digit 5. Although this is not courtroom level evidence of falsification of the data, it is sufficient statistical evidence to cast doubt upon the results of the study." And so what we're saying in our paper, which by the way was not funded by industry, the deans of the College of Pharmacy who paid our salary, Dr. Hatton and I, allowed us to work on this because it was within the spirit of what the College of Pharmacy stood for. And it was just, we got our routine salary, so that we were not of any incentive to find that it didn't work. So we filed a citizens petition in 2007 asking the FDA to increase the maximum dose in patients 12 years and older. As pharmacists, we know the science of drug being absorbed from the gut. If the 10 milligram dose that's approved by the FDA is not being absorbed, we thought, well, just increase the dose and you can overcome the effect of poor absorption. So we did ask them to require additional studies to validate that the 25 milligram would be more effective than 10. And we asked them to withdraw approval for children under 12 because it was approved by the FDA down to age 2, but it had never been studied in children. So neither the efficacy nor the safety of this drug had ever been studied, and this is not an exception to the rule. This is pretty wide in terms of lack of pediatric evidence. So we try to get the FDA to make these changes, and we were ignored. And so finally, after several attempts, we contacted Representative Henry Waxman, who was on the Committee of Government Reform. He was a California House of Representatives member who had a special interest in the FDA, and he wrote a letter to the director pointing out our study and the results, and it was ignored. He actually wrote 3 or 4 letters and finally got them to convene a panel of outside experts, the non-prescription advisory committee, to review the data and to come up with a conclusion as to whether we were right or wrong. And what that advisory committee said, the first question they were asked is, given the available data that exists, the evidence is supportive. You notice I have it underlined in bold because it wasn't, it is cautionary by saying it was supportive, that the 10 milligram immediate release formulation may be effective, and 11 of the 12 members voted yes. They also said additional studies are needed to assess the efficacy and safety of higher doses like the 25, and that was yes. Nine of the 12 voted for that. That was disappointing to then the director of the non-prescription division at FDA, because he didn't want to have to go through this process and have to change the monograph. He said this to a reporter who was interviewing him, so that's how I know. So
when sinus pressure from a cold or allergies start to build, all you want is relief. Relief from sinus pressure, from feeling so stuffed up, so congested. You might just blow. That's why there's Sudafed PE. The medicine in Sudafed PE is clinically shown to relieve nasal congestion in minutes. Sudafed PE. Get your head back where it belongs. And for relief of your cold symptoms, try Sudafed PE Severe Cold.
Liar, liar, your pants are on fire. So Shearing Plow, who were the manufacturers of Claret and D at the time, took their advice, committee's recommendation and conducted some studies. This was the first study. It was measuring the change in nasal congestion in patients who had chronic nasal stuffiness, and they had administered on different occasions the open, there it is. The open circles are the phenylephrine. The open box is the pseudoephedrine, which is the stuff behind the counter. And then then the placebo was the triangles. Placebo meaning they took a tablet, but it had no active drug in it. And you can see that the nasal congestion decreased significantly with the pseudoephedrine, but that with the phenylephrine, it wasn't different from the placebo. There was a drop. We call that a placebo effect. Patients are told that it's going to help them, and some patients get some relief, even when it doesn't really provide relief. And in a second study they did, and this was a large study in 539 patients with allergic, what they used to call hay fever. They tried different doses. So 10 milligrams was the FDA maximum approved dose, and they gave up to 40 milligrams, or 4 times what was recommended. And you can see that the black line, which is the placebo, and the 4 times, none of the doses were significantly different from placebo. So even increasing the dose didn't increase the benefit from the drug. Now, what happened when they went to publish these studies in an allergy journal, the editor of the journal asked us to review the article and make an editorial comment. And so we did do that, and in the process of reviewing it, we were just amazed at how ineffective this was, and how this study was so much better than what was done back in 1976, and it really confirmed what we suspected from our meta-analysis. So we filed another citizens petition. This time we asked them to pull the damn drug off the market. Petitioner requests FDA to issue a final rule removing oral phenylephrine from the final monograph for OTC nasal decongestant drug products, and to remove phenylephrine bitartrate, which was another product, from the 2006 amendment. Based on 5 efficacy and clinical pharmacology studies conducted after that original panel. So this was the new data. And that was in 2015, and even though we continued to contact them once a year, it wasn't until 2023 that they decided to do something. And they had brought back a medical review officer from the pulmonary division who had been expert in this area, and he put together an interdisciplinary panel of experts, statisticians, pharmacologists, etc., and they reviewed every bit of data in the English language, including everything that was submitted back in 1976 and everything that was since shown. And their conclusion, and this is what they presented to the advisory panel: the methodological and statistical issues with all of the 1976 original studies are both substantial and substantive. Potential bias and data integrity, that's a nice word of saying they cheated, issues at the Elizabeth site, which contributed 5 of the 7 positive original studies, but new clinical pharmacology and clinical data are consistent, substantial, and believable, and they confirm that orally administered phenylephrine is not effective at any dose that can be developed and still provide a reasonable margin of safety. So this was the scientific data reviewed by the inside FDA, and they presented this to the expert panel, which were all people who had no conflict of interest. They were allergists and ear, nose, and throat doctors, etc. And they voted 16-0 that the product was not effective. So that was in 2023. the Consumer Healthcare Products Association, which is the lobbyist for the companies that make the over-the-counter products, said phenylephrine is safe and effective decongestant. This is after the advisory committee meeting. And that the FDA advisory committee is at odds with the numerous clinical trials. So this is their whitewash. And this was on a TV program called Full Measure that was aired here in Gainesville on the local CBS station. So they've got their head in the sand because of that $1.8 billion per year. CVS immediately pulled the Sudafed PE off the shelves, but it was in 260 other products that they continue to sell to this day. None of the other pharmacy chains took this action, though. So they believed our data, too. And recently, which was 18 months after the advisory committee, FDA moves very slowly, and they're not going to move at all now that they've fired all of those people that worked there. And this was a proposed administrative order. So they've given the public 6 months to make their comments, and they will look at the comments and the drug company's opposition to what they're proposing, and they will make a judgment to whether to remove it from the marketplace. My worry is now that the FDA is under siege. They didn't have enough people working for them before this, I was on a visiting professor in the pulmonary division in '94 for 9 months, and I was impressed at how hard they worked, how bright they were, but that they had no support staff. So the medical review officers had to do their own Xeroxing, they had to do their own typing of the reports, and they just didn't have the kind of support that they should have had to efficiently and in a reasonable amount of time get their work done. At any rate, so we're still waiting. In May, the FDA will supposedly make a decision on whether to remove it, and they probably will give industry a year to make the changes. So just to review, the take-home messages are oral phenylephrine is ineffective as a nasal decongestant, but safe, big deal. 99% of the oral dose is inactivated by first pass metabolism, meaning that it's inactivated in the gut, so it doesn't get into the bloodstream. That's why it's safe. And in 1976, the over-the-counter panel reached a specious conclusion. That specious means that it looks like it was the right conclusion, but it wasn't. And we think that's because there was some integrity issues involved. And lastly, several truly effective over-the-counter products are available, like nasal steroids. And so there's removing it is not going to harm, or not going to deprive patients for anything. And I will stop at this point and take any questions that you might have. Don't change it, because I've got some backup questions depending upon what they ask. Yes, sir.
Could you list some of the product names for the nasal steroids that are effective?
Sure. So nasal steroids are effective for patients who have stuffiness from allergy symptoms. In fact, they are silver bullet. If you suffer from allergic symptoms, it stops sneezing, it stops runny nose, it stops red, watery, itchy eyes, and Flonase is the most popular. Nasonex is another one, and Nasacort. Those are the three brand names that are over the counter, in front of the counter, And they were originally prescription and they were switched over because they very little of the drug gets into the blood, so that it's very safe to use. They are not effective for stuffiness that's caused by a cold. When it's a virus causing the cold, it's a different mechanism. And one of the, they're not effective. And patients who have allergies shouldn't be taking the nasal stuffiness, nasal decongestants, because they can get hooked on it in the sense that it causes rebound congestion. So in people who have allergies, if you spray phenylephrine in your nose or Afrin in your nose, it gives you immediate relief, but then after several days, it makes your stuffiness worse. In patients with allergies, on the other hand, the nasal steroids are the very best drugs to use. In patients who have a common cold, which we all get, I have a bottle of Afrin. I always keep a fresh bottle of Afrin in the medicine cabinet, because it gives you relief of your nose stuffiness from a cold within minutes, and you get to sleep. If it's especially keeping you awake at night and you can't sleep, a couple squirts in your nose of Afrin or phenylephrine. Phenylephrine is a good drug. In fact, to this day, eye doctors use it in your eyes to dilate your pupils. It is available in a nasal spray for colds. And then if you're having surgery and your blood pressure drops during surgery, anesthesiologists use the drug into your veins to immediately reverse a drop in your blood pressure. So it's a good drug, except when it is swallowed, because there are enzymes in the gut that destroy it. Did that answer your question? It was a long answer.
My nose is clear while I'm vertical, but when I lie down, it stops up, and it stops up on the side where it's against the pillow, right? And if I change position, then it changes. So it's like maybe there's a polyp in there. But anyway, that's not my question. On the way driving over here, I learned that historic data is being obliterated across the administration. Weather data, all kinds of data, and as well as the data management tools. And so there are thousands of outside the government IT professionals who are scrambling to recreate, to save the existing data and the data management tools. Have you seen any of this with the FDA?
No, I haven't, but I wouldn't be surprised. It would just be absolutely inconceivable to me that they would not save whatever the data that is in the FDA system. I mean, it's, you know, I just couldn't believe that they would. And there's no reason to do that. I mean, there's no rational reason to do it.
It doesn't make any sense. Why would they delete the data? It's just like covering up something. Yeah.
Yeah, I guess it depends on what kind of data. And what you heard, I doubt, relates to efficacy and safety data of drugs.
The staff, the dam inspection staff, have been ordered to stay in the office. Their data is being deleted for
Yeah, but
dam
I guess
inspection.
I don't know what kind of data it is, you know.
Dam,
if
for
it's
hazardous
personnel
dams.
data
Yeah.
or payment, you know, so,
Yeah,
I mean, it certainly couldn't apply to Social Security. How would they mail out the checks?
right.
Yes, Jim?
Do we have more questions?
Jim does right here.
Here, I'm bringing you the.
I'm trying to figure out what's going on. I have been using, as I was discussing earlier, the little red pills. I am very susceptible to various things causing my nose to run or sneeze. And, that's been in my life, and I'm 88 years old today. And if I understood you correct, you're saying that what I have found works wonderfully for me is totally ineffective.
Oh, no, that's quite the opposite.
Yeah.
Remember, there were two, let me pull up the slide again.
Maybe I can just, take a pill and think about what it's for and it'll work.
So again, there are two Sudafeds. This
Right.
is the one you've been taking that works for you.
Right.
And this is the one where they substituted the phenylephrine ingredient,
Right.
and it's in front of the counter. This is behind the counter. So you can still get this. You just have to show your driver's license. Are you 18?
Yes,
You're at least 18.
I've done, I'm sure my name is on that list.
Okay. So you can still get this.
Yeah.
You just have to show your driver's license, and you can only get 120 tablets in a month, and that's more than anybody
I
needs.
don't need more than that.
This is what's behind the counter. It's also in gas stations, on cruise ships, in airports. And this is the one that people think is the same thing, but people get confused because they just don't know that there are different ingredients. And this is being pawned off as the same thing as the other. In fact, it was the fact that people would get the PE and then complain to pharmacists in Florida. We had a drug information center in hands that Randy Hatton was the co-director of, and he got phone calls from pharmacists around the state that was saying people are saying it doesn't work, and then that's how he got to look into it, and then he came to see me because I had written that other article,
Right.
and that's where we got the start. Is there anybody on Zoom that had any questions?
Yeah, would you check online, if there's anybody online with a question? Any more questions here? Yeah. Coming.
My pleasure. It's been fun to do.
So some of the allergy pills have, I think, Allegra D or Zyrtex D. So which Sudafed is the D in those?
So that's a good question. So she wants to know, there are 3 products that still have pseudoephedrine in it, and they're sold behind the counter: Allegra D, Claritin D, and Zyrtec D. The companies were aware of this data. In fact, one of the Claritin D company was the one that did those other studies that showed, the new studies that showed it didn't work. And so they never changed the ingredient, whereas all the other companies substituted phenylephrine for the pseudoephedrine so they wouldn't lose the business on cruise ships and airport, et cetera.
What
Yeah.
does the D stand for?
It-
Just, I'm coming here. Hang on.
Correct. The PE stands for phenylephrine,
No, the
and
D.
the Sudafed, the D in Claritin D is decongestant.
Oh,
D is for decongestant. Now, I didn't mention that this isn't a single drug issue. There are loads of drugs on the over-the-counter market that are in the same situation. The most common, Mucinex, DM, has an ingredient that doesn't work either, and it has the same kind of data situation, except we haven't written any citizens petitions, and I don't have 20 more years to do this.
yeah, no, mine was the D, but this is a parallel that I have. I got macular degeneration, so I was getting these shots. And then I saw the ad in the news on TV, which said this drug, the old drug, was now very effective. And it was, after a few shots, you can spread the interval to like 4 months between shots instead of every month. So I asked my retinal specialist, I said, why don't you give me that one instead of the new one that I was getting? He said, it's the same drug. All they did was increase the dose. They made it into now Eylea HD, and it's still the same thing, but they just changed it because the
But they
patent
did
was
change the
final.
dose.
They just changed the dose.
Well, that,
And the dose, he said, by increasing the dose, you actually have an increased risk of strokes.
wow.
I said, let's stay away from it. But, you know, they play games with us, the pharmaceutical
So
industry.
here's another game that you probably, Ozempic has been reviewed, and the drug semaglutide is very effective at decreasing diet, but decreasing appetite, which results in weight loss. But it's not approved for weight loss. It is approved only for diabetes. They took the exact same drug in the exact same dose and got FDA approval, and I forgot the name for it, but it's got another, it starts with a Z, I think. Anyway, it's the same drug, same, but now it is approved, and your insurance companies will play tricks with you. If there's any suspicion that that they're prescribing Ozempic for diet control, they'll deny payment on it. That's a whole other story. Is the prescription benefit managers.
Okay, anything else? Thank you very much, Leslie. Appreciate the
It's my pleasure.
clarification on all
Thank you.
these drugs.